In the name of Allah, the entirely merciful, the especially merciful. The use of albumin in critically ill patients, is it a life-saving intervention, a costly relic, or a tool for a specific subset of patients? In this video, I am, Dr. Ahmed Aglan from Alexandria University, will dissect the physiology, examine the landmark trials, and translate the evidence into practical guidance for the ICU. Welcome. Before we can discuss the role of albumin in critical illness, we must first understand its fundamental physiology. This slide outlines the key functions of albumin in homeostasis. First and most famously, albumin is the primary regulator of colloid osmotic pressure, which is essential for maintaining fluid balance within our vascular system. Second, it acts as a crucial transport molecule, binding to and carrying a wide range of substances, from hormones and fatty acids to drugs, through the bloodstream. Third, it has significant antioxidant properties, acting as an extracellular scavenger that neutralizes free radicals and protects tissues from oxidative stress. And finally, though often overlooked, it serves as a supplier of amino acids for peripheral tissues, supporting critical cell and matrix synthesis. So, in a healthy state, albumin is far more than just a number on a lab report, it's a multifunctional protein vital for stability. Now, let's quantify the scale and distribution of albumin in the body. First, the total body pool of albumin is substantial, measuring between 3.5 and 5.0 grams per kilogram of body weight. For a typical 70 kilogram adult, that translates to a total of about 250 to 300 grams of albumin. However, and this is a critical point, only a minority of this, about 30 to 40%, is actually found within the plasma compartment, which is what we measure with a standard blood test. This gives us the plasma concentration we're familiar with, around 30 to 40 grams per liter. The majority, 60 to 70%, resides outside the bloodstream in the interstitial spaces of tissues like the skin, muscle, and organs. This large extravascular pool isn't stagnant, it's in a dynamic equilibrium with the plasma. The interstitial albumin is continuously returned to the systemic circulation via the lymphatic system, which drains back into the central veins. So, the plasma level is just the visible part of a much larger, dynamically circulating pool. Building on that distribution, we now look at some critical nuances. First, not all of that large interstitial pool is readily available. Approximately 10% of interstitial albumin remains tightly tissue-bound and is unavailable for mobilization. This is a key reserve that we cannot easily tap into. Now, let's focus on a specific organ, the lungs. The albumin content in the lung interstitial tissue alone is substantial, about 70 to 80 grams. This highlights the lungs as a major reservoir. Under normal conditions, the pulmonary lymphatic system is exceptionally efficient at clearing both this albumin fluid from the interstitial spaces, preventing edema. Finally, let's talk about turnover. The movement of albumin is constant. It leaves the circulation at a rate of about 5% per hour. Let's do the quick math, that's 5% of the total plasma pool of, say, 40 grams. So, 0.05 times 40 grams equals about 2 grams leaving the vasculature every hour. However, this calculation of 6 grams you see on the slide likely accounts for the entire transcapillary escape rate, not just the plasma loss. The crucial point is that an amount comparable to this output is returned to circulation via the lymphatic system every hour, maintaining a delicate steady state. Now, we reach the heart of the problem in critical illness. The delicate balance we just described is shattered. Point 7 is the central issue. In a critically ill patient, the transcapillary leak skyrockets. It doesn't just increase slightly, it can jump from 5% per hour to a staggering 30% per hour. Using the same math, that's now up to 36 grams of albumin leaving the vasculature every single hour. It's no wonder we see such a rapid and profound early drop in serum albumin. The vascular compartment is being drained. This catastrophic leak is compounded by other losses. Point 8, albumin is also lost into the intestinal tract, at about 1 gram per day. While this seems minor compared to the capillary leak, it's another drain on the system. And for context, point 9 reminds us that in a healthy state, the kidneys are remarkably efficient, with minimal urinary loss of only 10 to 20 mg per day. This underscores that the massive losses in critical illness are pathological, not normal. Now, let's look at the body's long-term management of the albumin pool. After the initial rapid distribution, we see a slower, ongoing process. Point 10 describes the fractional degradation rate, or FDR. This is the baseline rate at which albumin is naturally broken down, about 3.7% of the total body pool per day. For a 300-gram pool, that equals about 11 grams per day. The elimination half-life based on this turnover is long, about 19 days. Point 11 reveals the beautiful balance of homeostasis. In a steady state, this degradation rate is perfectly matched by the rate of synthesis. The liver produces new albumin at almost the same rate, about 3.8% of the pool per day, or roughly 10 grams, to replace what is lost. This brings us to point 12, the source, the hepatocytes in the liver. Under normal conditions, they produce 10 to 15 grams of albumin every single day. A key point for understanding stress responses is that there is little to no intracellular storage of albumin. The liver must synthesize it in real time to meet demand. Now, what controls this vital production line in the liver? Albumin synthesis is tightly regulated by a hormonal balance. It is stimulated by classic anabolic hormones, insulin, which promotes building and storage, cortisol, in its basal state, and growth hormone. However, and this is the vital point in critical illness, synthesis is powerfully inhibited by the very pro-inflammatory substances that are unleashed in a systemic inflammatory response. Key among these are interleukin-6 and tumor necrosis factor alpha. So, in a critically ill patient, we see a double hit, a massive increase in loss from the capillary leak coupled with a profound suppression of production due to the inflammatory cytokine storm. This is the pathophysiological rationale for the persistent hypoalbuminemia we observe. Thank you.